The second part of the webinars that are covering the body fluid compartments. This part will cover the principles of osmosis as well as edema. Now in Physiology 1, you learned about hydrostatic and osmotic pressures and their role in movement of fluid out of blood vessels or into lymphatic vessels or going into back into blood vessels. Now the hydrostatic pressures are, like when you think hydrostatic pressures, you always think kind of like blood pressures. They tend to drive fluid out of plasma into the interstitial spaces and also from the interstitial spaces into lymphatic vessels. Osmotic pressures, which are the ones that we're going to be concentrating more about today, those are responsible mainly for returning fluid back to the blood, into the plasma, and also regulates the movement of fluid into and out of cells. The osmotic effect that we're going to be discussing about looking at the movement of fluid into and out of cells is because of electrolytes such as sodium and chloride and potassium, with special emphasis on sodium, since the sodium is a very major component of the extracellular fluid. One of the biggest things that affect the movement of fluid into and out of the cells is changes in sodium. If you remember the principles of osmosis, if I say, okay, define osmosis, most of you can rattle something off for me. It's the movement of water across the selectively permeable membrane from its high concentration to low. Okay, that's like it's a passive process, but when you think about osmosis, I want you to think about Maffei's principle. It says water will go where the osmoles go. It goes from a region of low osmolality to a region of high osmolality. What are the osmoles? Think of things like proteins and sodium and things like that. It's drawn to the solutes. So that's something I knew you already knew anyway, but that's something I want to really concentrate on. Water wants to move across membranes to the point where you always have osmotic equilibrium, that the osmolarity inside and outside of the cells will be the same. Now, something that I need to discuss is the difference between osmolarity and osmolality. Often I'll use them interchangeably, and I'll tell you why. But remember what an osmole is. An osmole is a mole of solute particles, 6.02 times 10 to the 23rd solute particles. Glucose. If I had a mole of glucose in a liter of water, I would say it's 1 osmole per liter. Sodium chloride, though, if I have a mole of sodium chloride in a liter of water, it's actually equal to 2 osmoles per liter, because if you put sodium chloride in water, the sodium and the chloride separate from each other, and both sodium and chloride are osmotically active, or they're effective osmoles. So you really have 2 osmoles of solute particles in that liter of water. Generally, though, when we start in later discussions and we talk about osmolarity or even osmolality, we'll use milliosmoles. So it's 1 milliosmole is 1/1000th of an osmole. So that's something that will be, if I give you osmolarities, it's always going to be in milliosmoles per liter. Now, the subtle difference between osmolality and osmolarity. If I say osmolality, we're talking about number of osmoles in a kilogram of water. If I use the term osmolarity, that's the number of osmoles in a liter of water or solution, since pretty much we're water, I'm just referring to water. Now, the reason why sometimes I'll use interchangeably is the fact that pure water, a liter of pure water is a kilogram. So pretty much lots of times I'll go back and forth because they're very close to the same thing. As a frame of reference for later discussions, the osmolarity of our body fluids is about 300 milliosmoles per liter. That's just something just to think about at a later time. Don't try to memorize it right now. Now, something that's not in your notes that I really kind of want to address is what constitutes an effective osmole. remember, this would be kind of like it's just a kind of corollary to Maxwell's principle, is that the movement of water across membranes is governed by the distribution of osmoles. Remember, it follows wherever the osmoles are. But an osmole is only considered an effective osmole if that solute does not freely cross the membrane. So if I throw that osmole into, say, solution, if it just rapidly moves across the membrane, it's not considered an effective osmole. Sodium is considered an effective osmole. If I threw sodium solution, water would be obligated to follow where the sodium is, because sodium does not really quickly move across membranes. It moves across membranes, but you need all these transporters to do, so it doesn't rapidly move across membranes, so it's an effective osmole. Glucose is an effective osmole. Urea is not. Urea membranes are pretty permeable to urea, so it will rapidly move across the membrane, so it's not considered an effective osmole. So just think about, if you add an effective osmole to one side of a membrane, it will osmotically obligate water to flow to that side of the membrane. That's what I want you to think of. If I put that in, water is obligated to follow where that is to try to keep the osmotic equilibrium. So if we review with you a concept that you've learned about in the past, the fact again that water wants to maintain osmotic equilibrium between the ICF and the ECF. If, for example, I place a cell, like a red blood cell in these pictures, into a solution, what will water do? Will it move into the cell, outside the cell? Would you have them moving equally inside and outside the cell? What would it do to volume? So if someone starts talking to you about tonicity, talking about isotonic or hypotonic or hypertonic solutions, what they're talking about is they're referring to whether or not the solution can cause a change in the cell volume. So if I throw, say, a red blood cell into an isotonic solution, that means the solution has the same osmolarity as the cell. And because of that, there will be no net change of fluid into and out of the cell. Water will be moving back and forth, but there will be no net change. So the volume remains the same. So this top picture, this picture over to the right would be an example of what you'd say if you threw a red blood cell into a solution that was considered to be isotonic. And we're assuming when we say isotonic that the solutes are impermeable. So the solutes will not move across the red blood cell membrane. If I throw that red blood cell into a solution that was hypertonic, that means the solution has a higher solute concentration relative to the cell. Again, water is going to be obligated to move wherever those effective osmoles are. So it's going to follow where the solutes are. So if the solution has more solutes than the cell itself, which you see right here, water is going to move out of the cell into the solution, so then by the time when you're done, the osmolarity will be the same inside and outside the cell. But what's happened to cell volume? It's gotten smaller. So it leaves us with the last scenario. If you throw a red blood cell into a hypotonic solution, that solution has a lower solute concentration relative to the cell. And so again, water is obligated to follow where the solutes are. So it's going to be drawn into the cell. Overall, what will happen? The cell volume will increase. And it could potentially, the cell could actually burst. So what would be a consequence of a change in cell volume? If you change cell volume, it can change how that cell works. So you don't want the volume to be too high or too low because it could affect certain functions that the cell does. Another thing we can talk about is very similar. When we talk about tonicity, we're talking about solutions that you have solutions with impermeant solutes. If I use the term isosmotic, hyperosmotic, or hypoosmotic solutions, the only difference, the subtle difference, is if I use those terms, is that the solution's osmolarity relative to the cell is irrelevant to whether or not solutes can penetrate the cell membrane. So, for example, if I have an isosmotic solution, that means the osmolarity of the cell and the outside the cell is the same whether or not solutes can penetrate the cell membrane. If it's an hyperosmotic solution, that solution has a higher osmolarity than what's inside the cell. Again, irrelevant of whether or not the solutes can penetrate the cell membrane. And then hypoosmotic, you could figure that one out for yourself. So, for example, if I have a solution that has urea in it, urea, I had mentioned, is not an effective osmol. It's highly permeating. It can go across membranes. So I could still compare the osmolarity of the solution that that particular cell is. And it's going to be irrelevant of whether or not the the solutes can penetrate the cell membrane or not. Okay? So what we're going to do, or you're going to do, is let's apply some important concepts. We talked about osmolarity. Let's see if we change certain things, what could potentially happen to the cell volume. Could it increase, decrease? What could happen to the extracellular fluid compartment? So 2 things to keep in mind. 1, water moves quickly across cell membranes. So you change something, water will move quickly as possible because membranes are pretty well permeable to water. At the final end, the ICF and ECF osmolarities will be the same when you're finally done. So water, all it wants to do is maintain osmotic equilibrium. 2, you're going to consider that cell membranes are almost completely impermeable to many solutes. So the only way we're going to change the osmolarity is if we're adding or removing solutes. Okay, so if we add or remove solutes from that particular fluid compartment, that's where we're going to change the number of osmoles. Okay, so just kind of think of that. What we're going to do is we're going to do a few situations, and we're going to see what could happen. So these are kind of what you need to do when you work through the scenarios. You're going to start about what's going on with the extracellular fluid compartment, because that's what I'm going to manipulate. What happens to the extracellular fluid compartment? If there is no change in the osmolarity of the extracellular fluid compartment, the only thing that you're going to see affected is the volume. It could be higher or lower. That's the only thing. If you do not change the osmolarity of the ECF, water is not going to be obligated to move across the membrane. But if you do change the osmolarity of the extracellular fluid, water is going to redistribute. It's either going to move into or out of the cell depending on what you did to the osmolarity. So for example, if I increase the osmolarity of the extracellular fluid compartment, water is going to be obligated to go from inside to outside the cell to balance the osmolarity between the 2 fluid compartments. So the final osmolarity will be the same, although it'll be higher or lower than normal. The ICF and ECF volumes will change because of the redistribution of water across the cell membrane. Okay? So, you'll notice you have some pictures in your notes. I'm trying to show you what the pictures are trying to depict. This is the net result that you would get based on what manipulation happened or what event happened. This is the final end product. If you'll notice here, this is trying to depict what could happen to the volume in these fluid compartments. So if you notice on this picture, the ICF volume is the same. I haven't changed that. The ECF volume is less, so I have some empty space here. If you look over here on this side, this is saying what has potentially happened to the osmolarity of the ICF and ECF. If you see it pretty much the same, the osmolarity did not change. If you see it over the black line, the osmolarity is higher than normal. If you see it below the black line, the osmolarity is lower than normal. And so the way that we're going to classify what has happened, you'll see these in bold. If there's no change in osmolarity, we're going to call it isosmotic. Whether or not we're going to call it volume contraction or expansion refers to what has happened to the ECF. So in this scenario, the osmolarity of the ICF and ECF has not changed, but you have volume contraction. You have less extracellular fluid volume. If you look over here, you'll notice this is called a hyperosmotic volume contraction because the osmolarity of the ICF and ECF is higher than normal. They call it volume contraction because the ECF volume has decreased. Over here, it's hypoosmotic because the osmolarity of the ICF and ECF is lower than normal. Again, it's a volume contraction because the ECF is decreased. Down at the bottom, these are all examples of volume expansions because you'll see an increase in the extracellular fluid volume. The same things in regards to isosmotic, hyperosmotic, or hypoosmotic refers to what has happened to the osmolarity. So I want you to do is I want you to look at the various clinical scenarios and see which of those scenarios would result in which of these things. Which of these would result in an isosmotic volume contraction? Which of them would correlate to this? So there's 6 of them. There's 6 of these. We need to match them up, but I'll help you a little bit. If you look at the different scenarios, you got 6 scenarios. Diarrhea. You kind of have to figure out what's happening in regards to osmolarity if there is a change, what's going on initially in the extracellular fluid, and then you need to go stepwise. Okay, where's water going to go if it will redistribute? What's going to happen to the ICF and ECF volumes if they do change? So diarrhea. If you have diarrhea, you're losing the contents from your intestines. You're losing not only water, but you're also losing electrolytes. Okay? I'm just kind of giving you a hint. You're losing both water and electrolytes. The second scenario, this is referred to as the syndrome of inappropriate ADH release. So these people are hyper-secreting anti-diuretic hormones. So they got buku amounts of ADH. So if you remember what ADH does, you should figure out what could potentially happen. So remember, ADH allows you to retain a lot of fluid, just the fluid. No electrolytes follow. So you retain lots of water. What would that do to the osmolarity of the ECF? And then subsequently, what can happen to the movement of water across membranes? Okay. Third scenario, you're just consuming a lot of salt. Just salt. We're not drinking the water with it. You're just consuming excess amounts of salt, which would be effective osmoles. Fourth scenario, you're lost in the desert. Okay, so if you're lost in the desert, you think, oh, I'm going to get, I'm going to get dehydrated. I'm going to be sweating to try to cool myself off. What could happen? Biggest thing when you get lost in the desert is you're going to lose a lot of more fluid than you do electrolytes. So you're going to lose a lot of fluid. Keep that. What could that do to osmolarity? Next scenario, if I give you a IV of physiologic saline. Physiologic saline is 0.9% saline. Physiologic saline means the saline is the solution is isotonic. It's an isotonic solution that you're given. So there's a reason why they prefer to give you physiologic saline instead of something like 2% saline or infuse you with just straight water. So they're infusing you with an isotonic solution. Last scenario, your adrenals are not working like they should. And specifically, if they refer to adrenal insufficiency, the example would be Addison's disease. So you're not producing mineralocorticoids or glucocorticoids. The big issue with adrenal insufficiency is the lack of mineralocorticoids. So aldosterone. You don't have aldosterone, you will not be able to reabsorb sufficient amounts of sodium. That's the big thing, is the insufficient reabsorption of sodium. That's the big one. You're like, well, water follows, but not enough to maintain osmotic equilibrium. Okay? So this is going on in the kidney, and a lot of things are different in the kidney. So you're going to not with lack of aldosterone, you're going to be losing sodium. So if you lose sodium, what's going to happen to the osmolarity of the ECF, and then walk through the steps? What's going to happen to water movement across membranes, and then subsequently what's going to happen to the ICF and ECF volume? So I want you to work on this by yourself. I always in class would have people get in a group and work through it. It's better to have you work through it than me. So I want you to pair them up, and then we can give you the answers at a later date. Okay, so I want you to work through that on your own. Now, last topic I do want to discuss, I can do it very briefly because we discussed this last trimester when we talk about edema. If I talk about edema, we're talking about you have excess fluid accumulating in body tissues. You can have intercellular edema, so you have extra water inside cells. Extracellular is one that we usually talk about the most, so that's accumulation of excess fluid outside the cells. Remember when we did a lecture on talking about, it was during the microcirculation lecture, I introduced you to the Starling's forces, and I said what determines whether or not water is going to move out of blood vessels into the interstitial space, or the water moving from the interstitial space to the blood vessel. And I said it was a balance of these hydrostatic and osmotic pressures. So remember that the different pressures, and if you know which ones are outwards pressures, which means it wants to move fluid out of the blood vessels into the interstitium. If you remember which ones are inwards pressures, going from the interstitium back into the blood, you could reason out which ones would cause edema. So this here, this is your capillary hydrostatic pressure, which is always an outwards pressure. It wants to move fluid out of blood vessels. This one is your interstitial fluid hydrostatic pressure. The interstitial fluid hydrostatic pressure, remember we had talked about that it could be an outwards or an inwards pressure depending on if I give it to you as a positive number or a negative number. But that potentially always could be a pressure that's going to want to move fluid back into the blood vessels. These two are osmotic pressures. This is the osmotic pressure due to, or in the blood, mainly due to the presence of plasma proteins. And the last one is your interstitial fluid osmotic pressure. Now this one over here, the osmotic pressure in the blood, is wanting to draw fluid into the vessel. Water is drawn to those negatively charged proteins. This one is wanting to draw fluid from the blood vessel into the interstitium. So this would be an outwards pressure. So I've given you some examples of things that potentially could lead to edema. One of them I said increased capillary filtration coefficient. This is a value that tells you, pretty much gives you an idea how permeable that blood vessel is. So what things can increase the capillary filtration coefficient? Histamine could increase it. We could also compare a different type of blood vessel to another. Different type of blood vessels have different capillary filtration coefficients. So what we're going to be pretty much talking about for the next few weeks is the glomeruli, kidneys. Glomeruli have very high filtration coefficients, so they let more fluid leave because it's all about filtration. If I increase the capillary hydrostatic pressure, that could lead to edema. So high blood pressure could lead to edema. Where we're going to apply it in regards to filtration in the kidneys is the hydrostatic pressure that you have in the kidneys is extremely high, but that definitely favors filtration, which is what we want in the kidneys. If you, say, decrease this pressure, you have maybe liver disease, malnutrition, protein deficiency, your plasma colloidal osmotic pressure can decrease, which could lead to edema. And you can see that evident in some people that are malnourished, especially with protein deficiency. They get ascites, kind of like the big bellies. So those are just different things that could lead to edema. And this is something we talked about last trimester, so this should be pretty much review. And we'll kind of be looking at this equation again when we look at what's going on in the kidneys. Now we do have some safety factors in place that tries to prevent edema from happening. So I'm going to just talk about this one first because we did it last trimester. Is if you have more fluid leaving the blood vessel and entering the interstitial space, the interstitial fluid hydrostatic pressure will begin to increase, but that will force more fluid into the lymphatics. So if you have increased lymph flow, that will prevent the fluid from accumulating in the interstitium. Now, because of relatively low compliance of tissues, this would be another thing that would help to prevent edema. And so what we're talking about here is we're talking about if you have fluid leaving the blood vessel, going into the interstitial fluid hydrostatic, or into the interstitium, that interstitial fluid hydrostatic pressure usually is in a negative range. If the compliance of the tissue is low, a very small amount of fluid will increase that pressure. And if I do that, if I make that interstitial fluid pressure less negative, that would oppose the movement of fluid out of the vessel. Because if the interstitial fluid hydrostatic pressure is negative, it does draw fluid out of the vessel. But if, because of compliance of the tissues is fairly low, a small increase in volume will increase pressure. So if you have more fluid leaving the vessel, that pressure will increase, which helps to oppose more fluid from leaving. And the last one, reason why you can help prevent edema, is if you have more fluid in the interstitium, that helps to decrease the protein concentration in the interstitium. And remember, the interstitial fluid osmotic pressure tends to draw fluid out of the blood vessel. So if you're kind of diluting it or washing the proteins away, maybe entering the lymphatics, that will help to, again, oppose more fluid leaving the blood vessels and entering the interstitial space. So we have a certain amount of edema safety factors. In the peripheral tissues, the margin that we have for before edema starts happening is about 17 millimeters of mercury. So if you remember kind of the average pressure in the systemic capillaries is about 17 millimeters of mercury. Generally, you'll start seeing edema happen when it gets up to about 34 millimeters of mercury because of that 17 millimeter of mercury edema safety factor. In the pulmonary circulation, that edema safety factor is actually much higher, or not much, but it's still higher. It's about 21 millimeters of mercury. The last thing, which again is something we've talked about last trimester, so it's kind of more of a review, is if I have excess fluid in potential spaces, like the pleural cavity, or the pericardial cavity, or the peritoneal cavity, or synovial cavities, they use the term effusion. So any edema in these potential spaces, they use the term effusion instead of edema. So normally we don't have that because lymphatic drainage usually prevents it. But if we do have that happening, we'll call it, like, say, pleural effusion, pericardial effusion, peritoneal effusion. That's the terms that we're referred to as. So example I had given you earlier about people that have protein malnutrition. Protein malnutrition can lead to ascites, and ascites really is an example of peritoneal effusion. So the fluid starts to accumulate in the peritoneal cavity. So this is the last part of this lecture. So remember, for this lecture, there will be 5 questions that you need to answer from the first part, and then you have to work through those 6 scenarios and figure out which scenario corresponds to isosmotic volume contraction or isosmotic volume expansion, etc., etc.